Hello and welcome to Clinical Laboratory Medicine Nasal Swabs PowerPoint. So I'm Alex Alexander, and since I don't have to do this in 10 minutes, I don't have to talk maybe quite so fast, but likely I will anyway. So what's a nasal swab? Well, you can read that, how a nasal swab is collected. A nasal smear is obtained by collecting cells using a cotton wool swab, and it talks about how you move it along the nasal mucosa from the anterior to the posterior part and then smear it and fix it and stain it on a glass slide. And then in the second star point there, it tells that technique samples cells from both the nasal fluid and the superficial layer. And it's pretty simple to perform, but as you can see, the cellular yield is usually small and has a poor reproducibility. So that reduces its applicability. There's a lovely picture of someone collecting a nasal cavity swab, and that is just in the nares from the looks of where that swab is. Nasal swab versus nasopharyngeal swab. The nair swab is actually used to detect people who are colonized with MRSA or MRSA, methicillin-resistant Staph aureus. And then nasal and nasopharyngeal swab sometimes is a term used synonymously. And I have to tell you, I did a pretty extensive or exhaustive literature search to find people who could, write about the difference between nasal swab and nasopharyngeal swab used in practice. And personally, I couldn't find anything. So I've always just thought of a nasal swab being synonymous with nasopharyngeal swab. But, obviously there I can see now the error of my ways. So words are everything, and if we say we want a nasal swab and someone doesn't know what that means at the lab, then you might just get a nair swab. So I would be very specific, and in the future I certainly will be more specific. Though I must tell you, I've absolutely never in 400 years of working with people in various forms of medical and mental health practice sent someone for a nasal or a nasopharyngeal swab. So the rapid tests that are done in office are the only ones that I have ever personally used, and I suspect that that's going to be the same for you. So depends on what answers you'd like to have as to what you're going to order. So a nasopharyngeal swab, again, a sterile cotton tip swab. Remember the nair swab previously said cotton wool. We can discuss the difference between cotton and cotton wool if you don't know that already, or you can just Google it. That's what I'm going to do, just to remind myself. A sterile cotton tip swab is gently passed through. Isn't it interesting how Google has become, synonymous with anything we need to look up? I kind of love it. It's like, Google is the new Webster. Actually, the Urban Dictionary for me is the new Webster. Okay, so back to the PowerPoint here. So a sterile cotton tip swab is gently passed through the nostril and into the nasopharynx, and the part of the pharynx that covers the roof of the mouth is what we're referring to here. And then the swab is quickly rotated, and boy, let's emphasize quickly there, and then removed. It can be cultured or it can be collected for rapid tests to detect influenza and other infections. So all I can think of is My Fair Lady when I think of influenza. If you haven't seen that movie, I strongly recommend it. Okay, so next slide there, how to swab a nasopharynx. These are two really excellent pictures, and I like the way they say gently pass through the the nostril and into the nasopharynx, because if you've ever had a rapid nasopharynx swab, it's not rapid or gentle. So just go ahead and tell your patients up front this is going to kind of suck your will to live. So just don't breathe for a few minutes and let's just get this over with. So what are we looking for here? So the test identifies viruses and bacteria that cause upper respiratory tract infections or symptoms. And the rapid test can identify, well, this says influenza A or B. I say this like I had nothing to do with it. My bullet point here says rapid test can identify influenza A or B, and that is true, and they can. But some of the tests that you purchase for your office, you might pick the cheap one, and it actually only identifies one or the other. So you want to make sure you're reading or talking to your rep who's coming in to try to sell you all these, your lab rep who's going to sell you all these tests. Nasopharyngeal cultures are useful in identifying respiratory viruses and specific bacteria like Bordetella pertussis, Neisseria meningitis, and Staphylococcus aureus. I'm sure you guys are all enjoying Umizoomi in the background here. I have the 2-year-old today, and he's hypnotized with Umizoomi right now. So if you hear that, my apologies. It's actually kind of a good episode, and at least it's not the Fresh Beat Band. Okay, so why swab? Nasal and nasopharyngeal swabs are clinically useful in primary care in several conditions. But influenza is the most notable. So let's start with sinus infections. And I put infections in quotations there because not all sinus problems are infections. So rhinosinus, how about rhinosinusitis? From Family Practice Notebook, this is where I got this from. It's just really nice to know where these resources come from, I think. So if ever you're confused and curious and you want to know where the heck I got one of these, things that I put on a slide here and expect you to believe just because I said so, please ask me where I got the source or the material or the information, and I'll be more than happy to provide that to you if I haven't already, because I can say anything I want to, and it's just the world according to me. But unless we back that up with something somewhere, it's just, again, the world according to me. So this actually came from Family Practice Notebook. And so what are we going to do with rhinosinusitis? Well, we're going to talk about the culture of the nasal mucosa from the nasal swab. And so we'll look at number 1 here. It's not cost-effective or helpful in management of rhinosinusitis. So what does this tell you right away? You're not probably going to do it. It doesn't correlate with sinus mucosa cultures, and it's not recommended unless you use the sinusitis prediction rules first. So let me read that again. You recommend to yourself in this case, I'm recommending to you, the students, to use the sinusitis prediction rules for diagnosis before you go hanging out with cultures and things like that. So, all right, so next slide is an algorithm for the management of acute bacterial rhinosinusitis. And so I see that, Micah. I see that is a Hot Wheels wall track. So why don't you go ahead and continue to be hypnotized there for a minute. Let's see what comes on next. Yes, that is the Cat in the Hat. Okay, so signs and symptoms we have on the top there. Persistent and not improving for greater than 10 days, severe greater than 3 to 4 days, or worsening or double sickening at greater than 3 days. And we're going to talk in class about what that double sickening means. So then you follow your algorithm down, and then you get to the bottom there, and you decide if you want to do what you want to do once you get to the bottom. But I'm wondering if you see anywhere on there that it says we should culture. No, as a matter of fact, until you get to the very bottom where it says refer to specialist for CT or MRI to investigate non-infectious causes of suppurative complications, sinus or meatal cultures for pathogen-specific therapy. We're not going to do that in our office. We're going to refer to a specialist. All right, next, current guidelines for cultures. In the previous algorithm, the absence of a culture or swab until the very end is very notable. So let's pay attention to that. And then we want to know that influenza has guidelines, and we want to know that pertussis has guidelines. Bordetella pertussis. Those of you who have dogs, maybe they do this for cats too. It's kennel cough. So Bordetella is kennel cough in dogs. All right, so influenza. Detection of influenza A and influenza B from Family Practice Notebook. So what are the advantages here? So number 1, we have a rapid assay for influenza in the clinic setting. And number 2, it allows early inhibitor neuraminidase inhibitor starting. So you can start with the prophylactic. I guess it wouldn't be prophylactic. It would be to the antivirals at that point. And it's indicated for high-risk populations. So what are the disadvantages of the influenza culture, the rapid? It's expensive in combination with the neuraminidase inhibitors, and the prevention by influenza vaccine is much less expensive. And now let's talk about rapid influenza diagnostic tests now. And they're basically rapid antigen point of care tests, and they're capable of identifying flu A and B, viral types in respiratory specimens, and get this, 10 to 15 minutes. What? That's so awesome. RIDTs are immunoassays, and they come in user-friendly diagnostic kits with varying complexity. So again, here it says they can only detect A, or they can detect but can't distinguish between A and B, or they can both detect and distinguish between A and B. And then RIDTs are valuable because they produce results in a timely and clinically relevant manner that facilitates your on-site point-of-care diagnosis of flu. That, according to the limited research, has led to a decrease in the demand for further diagnostic tests. So let's save those expensive chest radiography and blood culture tests if we don't need them. And also, it's prevented the use of antibiotics, which is going to result in decreased patient costs. And I'll say also antibiotic resistance. So one rapid test that I gave you a video for is the QuickView influenza test, and this one may be used in a CLIA-Wave lab, which by now hopefully you know what that means, and if you don't, go back and watch Dr. Acosta Smith's PowerPoint. And this one detects both influenza A and B, and it's an immunoassay for the nucleoprotein. Ask Dr. Kent. A, nasopharyngeal swabs or aspirate. So that's what we're doing there for the immunoassay for the nucleoprotein. Point number 4 there is 3-step process performed in 10 minutes, and the efficacy as compared with viral culture. On number 5 there is we have a test sensitivity of 73 to 81, a test specificity of 96 to 99, and it costs 15 to 20 bucks. So that's not too bad. All right, and then do you swab versus clinical judgment? And neither the rapid influenza test nor clinical judgment prediction rules are superior to clinical judgment alone in the diagnosis of flu. So let me say that again now that my son has quit yelling. Neither the rapid influenza test nor the clinical prediction rules are superior to clinical judgment alone in the diagnosis of influenza. So this tells you to pay attention in Dr. Lambden's class. Your clinical physical exam and what Dr. Acosta Smith is teaching you about your, how to hone your clinical, well, first develop and then hone your clinical judgment is going to really tell you what you need to know. In one study of 258 patients with 21% confirmed flu, the overall clinical judgment had a sensitivity of 29 with a specificity of 92, and we're talking about percentage. But then it was 67 and 96 when the patients presented within 48 hours. That's really high. So within 48 hours of symptom onset, sensitivity 67, specificity 96, using clinical judgment to detect influenza. And then the rapid influenza test only had the sensitivity of 33 and a specificity of 98, and the clinical prediction rule showed 40 and 92. And there's the reference there for where I got that nice bit of information. And so then who are we going to test? There you go. Who to test then? Yes, it is Dora the Explorer. I'm so excited that she's on. Yes, please watch Dora. What a great idea. Okay, so the patient presents to the ED, emergency department. I wonder why they went from emergency room to emergency department. Maybe because they didn't want you to feel like you're just stuck in a little room all the time, because that's actually true. And so if they tell you it's a department, then you feel like it's okay to sit in the room for a really long time. I don't know. I just made that up. So the patient presents to the ED. And is the patient's clinical presentation symptomatology compatible with an influenza-like illness? No, well, it's probably not going to be indicated. But yes, will influenza diagnostic test results, 1, influence the patient's clinical care, which this could be said for anything. I'm going to go off on a small tangent for a second. This is anything. Don't order the MRI if it's not going to change your treatment. Don't order any test that's not going to tell you anything or change anything. Don't order the MRI, especially those expensive imaging tests and those expensive, there's a lot of expensive tests, but don't order that stuff if it's not going to change anything. I mean, if the patient just wants to know because they're curious, they can pay out of pocket. Please do not waste the macro healthcare dollar on such frivolity. Okay, there's my soapbox. So influence the patient's clinical care, or 2, influence clinical management of other patients. This is really important. Think about that one. If yes to either of those questions, then consider the influenza diagnostic test. And if no, influenza diagnostic testing is probably not indicated. I really like that. It's simple. It's easy. So indications for testing for influenza, well, there's 2 kind of categories here. So during the season, testing should be done in the following persons if the result will influence clinical management. And that's the if there. Outpatient immunocompetent persons of any age at high risk of developing complications. Well, complications would be death, because that's complicated, or hospitalization, because that's complicated, scary, and expensive. Presenting with acute febrile respiratory symptoms 5 days or less after illness onset, when the virus is usually being shed. Okay, so that's going to be one category. The second category is outpatient immunocompromised. Now, bullet point 1 there was immunocompetent. Now we're into immunocompromised persons of any age presenting with febrile respiratory symptoms, irrespective of time since illness onset, because immunocompromised persons can shed virus for weeks to months. What? I am serious about that. I didn't write this. I stole this from the current guidelines, and I think the reference is probably coming up soon. If not, I'm going to tell you it's from the CDC. Immunocompromised persons can shed the influenza virus for weeks to months. You may not know who is immunocompromised and who is immunocompetent by looking at them. So you have to ask the right questions. And then hospitalized persons of any age, immunocompetent or immunocompetent. So either immunocompetent or immunoincompetent, which we like to say immunocompromised because it's less, it sounds nicer. Okay, so immunocompetent or immunocompromised with fever and respiratory symptoms, including those with the diagnosis of community-acquired pneumonia, irrespective of time since illness onset. Well, that's not really us right now, unless you're working at the Cancer Treatment Centers of America or one of the other, like a couple hospitals in the country that has naturopaths on staff. And having been to the Cancer Treatment Centers of America for a day and to see what was going on around there, I can tell you the naturopaths there are not making decisions about anything other than supplements and homeopathy. So definitely not going to be making decisions about flu. But hopefully that's going to change in the future because we are awesome and we have every right to be working in hospitals should we desire to. Oh, wow, this is like the soapbox video. Okay, so indications continued. Elderly persons and infants presenting with suspected sepsis or fever of unknown origin, irrespective of the time since illness onset. Children with fever and respiratory symptoms presenting for medical evaluation, again, irrespective of time since illness onset. Persons of any age who develop fever and respiratory symptoms after hospital admission, irrespective of time since illness onset. And then immunocompetent persons with acute febrile respiratory symptoms who are not at high risk of developing complications secondary to influenza infection may be tested for the purposes of, and here we go, obtaining local surveillance data. We need that stuff. I never really know if I want to say data or data. Okay, now what about throughout the year? So on the next slide there where it says indications continued throughout the year, if we back up 2 slides, we say indications for testing during influenza season. And we just went through all those. Now we're indications throughout the year. So testing should be done for the following persons. We have 2 categories. Healthcare personnel, residents or visitors in an institution experiencing an influenza outbreak who present with febrile respiratory symptoms within 5 days after illness onset. For obvious reasons. This should be intuitive. Persons who are epidemiologically linked to an influenza outbreak. Okay, and they define epidemiologically linked to an influenza outbreak as household and close contact with persons with suspected flu, return travelers from countries where flu viruses may be circulating, participants in international mass gatherings, and cruise ship passengers. Just don't go on a cruise ship, who present within 5 days after illness onset. So, I don't want to bust on the cruise ships, but all I have to say is closed system. Okay, and then here, and as I promised, is the reference to all that. And in fact, it wasn't the CDC. So what do we got here? We've got a 2009 study, or 2009 Clinical Practice Guidelines of Infectious Disease Society of America. All right, now pertussis. Pertussis. Bordetella pertussis. So what do we know about pertussis? Well, hopefully Dr. Sarah Costa-Smith is going to teach you something about pertussis, but what we mostly know about pertussis is the inspiratory whoop. So I'm not going to go into the clinical syndrome with you because this is the lab portion, and I don't want to belabor anything that Dr. Costa-Smith has already gone over. So I'm going to talk to you about the technique for obtaining samples. A polyester swab of the nasopharynx, and you insert this into the base of the nostril and leave the swab in place for 10 seconds. Number 2 is a nasopharyngeal aspirate, which we are not going to cover here because you're going to refer that out unless you're working with a physician who trains you to do nasopharyngeal aspirates. I will not be training you to do that. Higher efficiency than a swab and then requires special equipment. Now, Dr. Mueller may be training you guys to do aspirates, but I don't know that to be true, so I'm not talking about it. Okay, the next slide there. Culture is considered the gold standard because it's the only 100% specific method for identifying pertussis. The test not necessary if close contact of a laboratory confirmed case. So let's just say you're, as a patient of mine a few years ago came in and, my boyfriend has pertussis and now I've got these symptoms. Well, I'm just going to assume that my patient has pertussis and treat presumptively. There's no need there's no need for me to waste the resources on a test. And then testing for suspected cases, negative results do not rule out pertussis if clinically suspected. Another patient that I saw maybe last year before last, I can't remember, who came in. I mean, everything smelled like pertussis in the sense of all the symptoms and signs and clinical course and sound, and everything was all pertussis all day long, but the test results were negative, and so I'm still 100% certain that that person had pertussis. Okay, so clinical context: strongly consider pertussis if the persistent or worsening cough with no or low-grade fever in an infant less than 3 months, or in an infant older without any other, an older infant without any other explanation. And then here we go with the persistent or paroxysmal, I love that one, cough with no or low-grade fever and any of the following. So we've got apnea, cyanosis, post-tussive vomiting, which, it's so pathognomonic it's almost as pathognomonic as the inspiratory whoop. Seizure, pneumonia, non-purulent coryza, unexplained apnea spells, inspiratory whoop. So that is our strongly consider pertussis if. And then suspect pertussis if your cough is greater than 7 days in persons with no or low-grade fever and any of the following: the paroxysms, the post-tussive vomiting, and the inspiratory whoop. And then cough greater than 14 days with no or low-grade fever and no alternative diagnosis. Cough of any duration with no alternative diagnosis and any of the following: a close contact with a pertussis case or with a person with prolonged cough illness. And pregnant women in the 3rd trimester in close contact with infants or other pregnant women. This is like a vulnerable population for pertussis, babies and pregnant ladies. So, really suspect on the air, just err on the side of caution. All right, so tests recommended by the CDC, Centers for Disease Control, in beautiful downtown Atlanta, Georgia. Nasopharyngeal swab PCR is preferred, and this is indicated as a first-line test for pertussis. Test sensitivity is 94%, test specificity is 97%, and you get that result in 1 to 2 days. And you culture it for confirmation. And then I've given you a link to the CDC page on pertussis. I think you can probably cut and paste that into a browser. I'm not sure you can click from here. And then Pertussis Facts: endemic. What in the world does that word mean? Endemic, despite vaccination. And worldwide, there's an estimated 30 to 50 million cases of pertussis. An estimated 30 to 50 million cases of pertussis, and about, get this guys, 300,000 deaths per year. That makes me really, really sad. Approximately half of infants less than 1 year of age who get pertussis are in fact hospitalized. And I had the misfortune of, when our 2-year-old, who's currently being hypnotized, was about maybe not even 1, someone in our family friends group brought a child to our home who was not vaccinated and had pertussis, and we didn't know that until the child left. And so the children in my home, my kids, were all exposed. I wasn't worried about the 2 older ones, but the younger one was less than 1, and we had to put him through some pretty hideous testing and prophylactic treatment, because the morbidity and mortality in infants is just too high for me to want to take that chance with. And so the take-home message is, educate your patients to ask their friends during pertussis season not to bring their kids if they have a cough, and educate your family members and patients and friends about pertussis and how serious it can be for infants and pregnant women. Okay, so there you go. That's that one. And so in conclusion, this is the last slide, I think. Do swab or refer for suspected influenza per the guidelines. Do not swab routinely in rhinosinusitis. Do swab or refer suspected pertussis. And do swab or refer to test for MRSA colonization if clinically indicated. And I didn't really go into a lot on that testing for MRSA colonization. We can talk about it a little bit more in class, but this is basically if you have an immunocompromised person living in a home of someone who might have a colonization, and you want to just rule out that someone, you wouldn't want them to be exposed, or a clinical setting, a hospital setting where you swab all the healthcare workers on a particularly fragile ward or floor, because you want to make sure that they don't have a MRSA colonization that they're doing just fine with. So you're not swabbing for the person who might have the MRSA in their nose, in their nares. You're swabbing for the people that person cares for. Okay, so if you are someone who is colonized with MRSA, then you just make sure you engage in protective practices like hand washing and masking when needed, and that kind of stuff. And we can talk more about that in class. And on a final note, on the do not swab routinely in rhinosinusitis, I can't stress that enough, because you're actually not going to get the information that you want at our primary care level. So if you feel like you need to swab, send the person to a specialist. And in class, will recount my own story for you of having had my own, well, as a sick person, having a doctor swab me and finding something because of my work in other countries and with foster children that was actually normal flora at the time for me in my nasal, in my nasal cavity, probably in my sinuses, and then it being a big deal that didn't really need to be a big deal. So, it's why we need to know what we're looking for before we go on a hunt. Because in this case, the hunt turned up something that, disallowed me to go to my job because I was in quotations, colonized with, in this case it was Pseudomonas, and, and it really was nothing at all. And it's, on a secondary swab a year later, it's not there anymore. But it wasn't what was making me sick, is the take-home message. So you will find things that send you down a red herring path. So don't go looking for stuff unless you know what you're looking for and what the clinical usefulness of that is once you find it, which is why you just don't test for every possible thing you can, because you're always going to find information that adds up to nothing. Now, am I saying to you don't look for things that might hurt or kill your patient? Of course I'm not saying that. I am just saying don't go looking for a red herring, because you'll always find it. Okay, guys, I apologize for the noise in the background and having to entertain the 2-year-old, but this is just kind of the facts of life. And have a wonderful rest of your day. Thank you.